Hey everyone, welcome back. Today, we're opening up the ultimate clinical playbook. In this explainer, we're decoding some of the absolute highest stakes scenarios out there. We're going to be bridging the gap from complex, inherited genetic mysteries all the way to high adrenaline critical care emergencies. Because whether we're tracking down some elusive blood disorder or managing a literal life or death crisis in the ER, precision is everything. So I want you to consider this reality check for a second. Anaphylaxis is one of the few times when you would not have time to look up the dose. Talk about high stakes, right? The knowledge we're decoding today isn't just academic. It's strictly life-saving and incredibly time-critical. In these moments, you either know it or you don't.
Okay, let's dive into this. Here is our structural roadmap for today's investigation. We'll start with genetic blood mysteries, move on to decoding acute leukemias, look into testing for allergies, and then wrap it all up with surviving anaphylaxis. Let's get to work. Part 1, Genetic Blood Mysteries. Let's shift into an analytical mindset here as we start unraveling these inherited genetic disorders. First up on our list of suspects is acute intermittent porphyria, or AIP. This is a rare autosomal dominant condition. Now, mechanically speaking, what's happening here is a defect in an enzyme called porphobilinogen deaminase. Try saying that 3 times fast. But seriously, this enzyme is vital for making heme, and because it's defective, toxic heme precursors just start building up in the body. If you're on the lookout for this, it usually hits young adults, mostly females actually, at about a 5-to-1 ratio, and it presents with a classic triad: abdominal pain and vomiting, neurologic issues like motor neuropathy, and psychiatric symptoms like depression. Oh, and here's your massive diagnostic clue. Classically, the patient's urine will turn deep red when left to stand, so look out for that. Now, what's really interesting about this slide is how it perfectly maps out the dangerous triggers you absolutely have to avoid. It brings us to the mnemonic BOOST CHAP. That stands for barbiturates, benzodiazepines, oral hypoglycemics, OCPs, sulfonamides, tetracyclines, chloramphenicol, halothane, and alcohol. Give any of these to an AIP patient and you could trigger a severe acute attack. And pay special attention to that little note at the bottom. While chloramphenicol is dangerous, chlorpromazine is totally safe. It's an easy trick to fall for on a test or worse in the clinic, so lock that one in your memory for sure. Moving on to another genetic blood puzzle, alpha thalassemia. This is caused by a deficiency of alpha chains in hemoglobin, linked specifically to chromosome 16. And as you can see, the clinical severity scales perfectly with the number of affected alleles. It's basically a sliding scale of danger. If just 1 or 2 alleles are affected, you'll see a hypochromic and microcytic blood picture, but the hemoglobin level typically stays normal. But if you knock out 3 alleles, now you've got HBH disease, which features actual anemia and an enlarged spleen. And tragically, if all 4 alleles are affected, it's fatal in utero, a condition known as hydrops fetalis. The genetics here directly dictate the clinical outcome. Section 2, Decoding Acute Leukemias. Let's transition our investigation away from the genetics lab and step straight onto the oncology ward. We're going to start with acute lymphoblastic leukemia, or ALL. This is a malignancy of lymphoid progenitor cells, and it's actually the most common childhood cancer, usually peaking right between ages 2 and 5. When we contrast the outcomes, for a good prognosis, you're really hoping to see the FABL1 type, the common ALL or pre-B phenotype, and importantly, a low initial white blood cell count. On the flip side, the poor prognostic factors include the FABL3 type, the presence of T or B cell markers, the notorious Philadelphia translocation, and extreme ages, meaning under 2 or over 10 years old, along with a very high initial white cell count. Now let's compare that with acute myeloid leukemia, AML, which is much more common in adults. AML is essentially a story of bone marrow failure. Because the marrow gets totally packed with blast cells, the patient presents with anemia causing pallor and weakness, neutropenia leading to frequent infections, and thrombocytopenia causing bleeding. If you're assessing the risk here, the major red flags indicating a poor prognosis are being over 60 years old, still having more than 20% blasts after the very first course of chemo, and specific cytogenetics, particularly deletions of chromosome 5 or 7. Now, zooming in on AML, there's one highly specific subtype you just have to be able to recognize instantly: acute promyelocytic leukemia, or APML. This is the M3 subtype. So the crucial point here is why we single this one out. It's because APML is associated with a very specific T1517 translocation, and it presents in much younger patients, averaging around 25 years old. Most importantly, it often presents with severe bleeding due to disseminated intravascular coagulation, or DIC.
You have to identify APML incredibly fast because of those immediate massive bleeding risks. Which is crazy because, ironically, it actually has an overall good prognosis if you manage it correctly.
Chapter 3, Testing for Allergies. All right, let's pivot the narrative. We're leaving the hematology ward and heading straight into the immunology clinic. When we're trying to track down the exact culprit behind an allergic reaction, we've got a few handy tools. Let's compare the two main skin tests. With the skin prick test, you get a rapid assessment. You place drops of an allergen, pierce the skin, and boom, you read the wheel after just 15 minutes. It's cheap, it's easy, it uses controls like histamine and sterile water, and it's fantastic for food and pollen. By contrast, skin patch testing is your delayed investigation. You place 30 to 40 allergens on the patient's back, leave them for 48 hours, remove them, and then read the results a full 48 hours after that. This one is specifically geared toward investigating contact dermatitis. But hey, what happens when you just can't use the skin? Say the patient has extensive eczema all over their body, or maybe they're actively taking antihistamines that would just suppress a skin reaction anyway. That's exactly where we rely on the RAST, the radioallergy sorbent test. This is a blood test that measures the exact amount of specific IgE antibodies reacting to an allergen. It grades the immune response from a 0, meaning negative, all the way up to a strongly positive 6. It's an incredibly useful workaround for food, pollen, and even wasp or bee venom allergies when skin testing is entirely off the table. Chapter 4, Surviving Anaphylaxis. Okay, we need to ramp up the energy now. We are transitioning out of the calm outpatient clinic and straight into a high-stakes ER scenario. So, how do we definitively diagnose anaphylaxis? According to the Resource Council UK, we need to clearly establish the diagnostic boundaries here. First, the reaction has to have a sudden onset and rapid progression. Second, and this is absolutely non-negotiable, the patient must have airway, breathing, and/or circulation problems. We're talking about swelling of the throat causing stridor, wheezing, hypotension, or tachycardia. Now, it is totally true that 80 to 90% of these patients are also going to have a massive rash, erythema, or hives. But look at the golden rule at the bottom. A rash alone is not enough. If there's no ABC compromise, it is technically not anaphylaxis. And this brilliantly illustrates the exact dosing for intramuscular adrenaline, which is hands down the single most important drug here. It goes straight into the anterior lateral aspect of the middle third of the thigh. You've got to memorize these age-based doses of 1 in 1,000 adrenaline immediately. Under 6 months gets 100 to 150 micrograms, 6 months to 6 years gets 150, 6 to 12 years gets 300, and anyone over 12 gets the adult dose of 500 micrograms. You can repeat this every 5 minutes if you need to. Seriously, lock these numbers in. Okay, but what if you give the adrenaline and it just doesn't work? Well, we call that refractory anaphylaxis. The exact definition for this escalation protocol is when respiratory or cardiovascular problems persist despite 2 full doses of IM adrenaline. At this point, the standard approach is failing to stabilize the patient. You need to immediately start pushing IV fluids for shock and urgently call for expert help so you can consider setting up an IV adrenaline infusion. Phew, okay. Let's say you successfully stabilize the patient. The immediate danger is past, but guess what? Your job isn't done. Here are the critical follow-up steps. You can give non-sedating oral antihistamines if they still have persisting skin symptoms like hives. Very importantly, you'll want to measure serum tryptase. This can actually remain elevated for up to 12 hours, and it serves as absolute confirmation that this was a true anaphylactic episode. And before they go anywhere, they must be referred to a specialist allergy clinic. Plus, you need to prescribe them 2 adrenaline autoinjectors, making absolutely sure you train them on how to actually use the things. Let's move on and see how this builds into the final step, sending the patient home. Because you can't just let them walk out immediately. You have to follow a strict timeline for risk-stratified discharge. You can fast-track them at 2 hours if they had a great response to a single dose of adrenaline and complete symptom resolution. You need to keep them for a minimum of 6 hours if they needed 2 IM doses, or if they have a history of biphasic reactions. And you hold them for at least 12 hours if the reaction was severe, meaning more than 2 doses, or if they have severe asthma, present late at night, or if there's any risk of an ongoing reaction from a slow-release medication. So what does this all mean? That brings us to our final thought for today's explainer. Biphasic reactions, where the symptoms suddenly return without new exposure, can occur in up to 20% of anaphylaxis patients. Knowing those odds and the strict protocols we just covered, ask yourself, would you be ready to safely risk stratify and discharge an anaphylaxis case? It is a high-stakes clinical reality that requires absolute precision. Reflect on those adrenaline doses, keep that boost chap mnemonic handy, and above all, stay curious. Thanks so much for joining me on this clinical deep dive. I'll see you in the next explainer.